So friends, I'll be just touching upon during my talk another 15-20 minutes. I'll be just touching on the COPD and asthma. I'll be just again talking about osteoporosis, especially in connection with the glucocorticoid induced osteoporosis. Its diagnosis, management and prevention. I'll be talking on certain newer aspect of the subject, especially the few research have come and certain innovation in the field of COPD. Let us move from this. A COPD female was recovering with the given medication from the COPD, but one fine morning when she woke up, she had huge back pain and she was unable to get down from the bed. She recalled on further inquiry, she went to the doctor and on further inquiry she could recall that from past few days she was also having faint pain in wrist and shoulder. It is a typical presentation of osteoporosis in a patient taking the drugs, especially the glucocorticoids. At times patient come and tell कि सर पूरे बदन में दर्द हो रहा है. It's a typical presentation. Again, those who are long-standing patient, long-standing on the inhaled corticosteroid and oral corticosteroid, and ultimately led to the development of osteoporosis. Let us talk about the COPD, another very, very important disease. When I just recall my postgraduate days, my teacher used to tell, डॉक्टर साहब कोई चिंता मत करिए, ट्यूबरकुलोसिस रहेगी आप जब तक रहोगे और आपको कोई कमी नहीं पड़ेगी. But things have changed and continuously changing. The change is that now what we used to tell our postgraduate student that the COPD is going to be your future. It is going to be one of the very important problem. And friends, when I say that my OPD attendance, almost 70 to 75% patients are having either asthma or COPD or their sequelae. So this is continuously changing. The whole, what we call, or better call it, the geography of the patient have changed over the years. When I used to sit in way back as in my postgraduate in a chest OPD, the 80% patient used to be tuberculosis and their sequelae, but now 70 to 80% are having not tuberculosis, the COPD and asthma. And COPD is going to be third most important cause of the mortality in the world. Friends, it is not only world. Southeast Asia means the main three countries are very important, the India, Pakistan and Bangladesh. Of course Nepal and Sri Lanka also included. The two problems, two major dreaded diseases, the malaria and tuberculosis, I must thank to the National Tuberculosis Control Program, it has been brought under the control. And the incidences are continuously coming down. But what about the COPD? It is really continuously increasing. And what about India? This data from the Maharashtra. And it's old data, almost 2008 and published in 2010. That COPD is one of the important cause of the mortality, then that of cardiac arrest, stroke, ischemic heart disease, accidents. And you just imagine the problem of COPD which we are facing. And unfortunately what is happening? The chest physicians are aware about the diagnosis and the management of the COPD. But unfortunately, most of the physicians who are treating patients of the COPD, thinking that this is a patient of bronchial asthma, and this is something not happening very good with the patients of the COPD. And what is required is a knowledge about the COPD, understanding about the COPD, that COPD is a different disease from that of the bronchial asthma. As for the treatment, I will not go details about the treatment. The gold guidelines and Indian guidelines of the treatment of the COPD is available. The focus of the treatment is on the self-management education. Smoking cessation remains always a very important part of the treatment. The bronchodilators are the sheet anchors of the treatment of COPD. Inhaled corticosteroid, of course, used in a severe and very severe disease just to prevent the acute exacerbations. Pulmonary rehab, unfortunately, not practiced in our country, but it remains a very, very important part, especially when we talk in context with this osteoporosis. Oxygen and the surgery, especially the lung volume reduction surgery, is very, very important. So these are the mode of the treatment of the COPD. COPD is not like a bronchial asthma, which is localized disease to the lung only. It is a systemic disease. It is like diabetes mellitus. It is like hypertension, having the extension not only to the COPD, one organ, lung only, but to the extension to the other organs also. The most important organ affected by and most important comorbidity of the COPD is the cardiovascular diseases. And to the extent that almost 50% patients of the COPD die not in the respiratory ICU but in a CCU because of the cardiac failure. And the second most important is the osteoporosis and muscle weakness. These are the second most important after the cardiovascular diseases. The second most important comorbidity is the cardiovascular, is the osteoporosis and muscular weakness. I said it is the prevalence of osteoporosis is a 66.6% in the COPD patient, and you can imagine every 2 patients out of the 3 patients of COPD are having the osteoporotic problems. A bit about osteoporosis. I will not go definition of the osteoporosis because I see the Dr. Gautam Chakravarti is sitting here, who is a learned person. He will be talking about the definition. I will just touch the epidemiology, the important part of the epidemiology. Half of the women over the age of 50 will have an osteoporosis related fracture. Very, very important, very significant problem. 24% of the individuals over the age of 50 die within a year following the hip fracture. So these are the important data, and just tell about the significance of the osteoporosis. And as for the incidence of the osteoporosis is concerned, it is combining the heart attack, stroke and breast. We combine 3 together. The incidence of the osteoporosis is much more than that of the 3 combining together. So you can imagine the problem, extent of the problem of the osteoporosis. Now question comes, why the osteoporosis is important to a chest physician? What is the concern? It is a pure orthopedic problem. So what is the concern? But it is very much concern to the chest physician, because the chest physician is the person who is using maximum corticosteroids. Many of our diseases, such as interstitial lung disease, such as the collagen vascular disorder, such as vasculitis, are to be treated only by the corticosteroid. You cannot help it without giving the corticosteroids, the systemic corticosteroid. And the 2 major problem of chest physician, the bronchial asthma and the COPD, one has to use the inhaled corticosteroid for the treatment. So when we are using the maximum amount of the corticosteroid, so we need to be aware about the osteoporosis problem. But unfortunately, many of us are not careful about the osteoporotic problem. The current use of anti-osteoporosis medication less among the chest physicians. These were the findings. And when I see chest physician and when I see myself, we really use less anti-osteoporotic treatment, anti-osteoporotic prevention when we use the inhaled and oral corticosteroids. Every patient receiving either oral or inhaled corticosteroid therapy is at risk for bone loss regardless of age, ethnicity, gender or other risk factor for non-glucocorticoid induced osteoporosis. Whether he is receiving the systemic corticosteroid, whether he is or she is receiving the inhaled corticosteroid, he is bound to expose a loss of bone loss and a risk to the osteoporotic problem. And this is how you measure the DEXA scan. I will not go about the DEXA scan and measurement of the osteoporosis. These are the risk factors associated with the COPD patient responsible for osteoporosis. The low body weight, the smoking, the age. Why age? Because the COPD is mostly the problem of elderly. In Western countries, the COPD develop usually 60 to 65 years, but in our countries, we are finding large number of the patient early age. At the age of 45, you got full-blown COPD. The gender, the inactivity. Since the patient is having the breathlessness, he is inactive. He is not physically active person, and ultimately very important risk factor for the development of the COPD. The systemic inflammation and the systemic corticosteroid therapy and vitamin D deficiency. Vitamin D deficiency is associated with the COPD. So these are the important factors which are responsible risk factor for the development of COPD in the patients of COPD, in the patient of osteoporosis. The COPD patients are more prone for osteoporosis related complications. And reason being, I said already, the COPD patients, females, are more affected by the problem than male. The osteoporotic problem is more prevalent in a female patient than that of the male patients. And you just see the prevalence of male and female COPD. As the disease progresses, the difference between the male and female is increasing. Now question comes, why female have more osteoporosis than that of the male? The reason is very simple. The women tend to have smaller, thinner bones than men. Estrogen, a hormone, a woman that protects in the woman that protect the bones, decreases sharply when woman reaches to the menopause, which can cause bone loss. That is why the chances of developing osteoporosis is much more in postmenopausal age than that of the. So a postmenopausal woman having the COPD needs to be treated differently, should be taken care of for the osteoporotic problems. The dose of the glucocorticoid is much less in the inhaled corticosteroid, but then also if it increases to certain doses, probably it is causing the osteoporotic problem. The prednisolone lesser than 5 mg cause much less problem than that of the prednisolone more than 7.5 mg. So depending on the dose, the bone loss is equally proportionate to the dose of the corticosteroid patient is taking. And what are the major connecting risk factors? Already said about the risk factor, but 3 important factors. One is the systemic inflammation, 2 is the vitamin D deficiency, 3 is the corticosteroid therapy or there in a patient of COPD, which are responsible for causing the osteoporosis. And the pathophysiology by glucocorticoid induced effect of the bone are mainly the reduced matrix mass due to the glucocorticoid therapy, enhanced osteoclastic activity, reduced osteoblastic activity. The osteoclastic is the bone resorption and the bone formation is osteoblastic activity. The reduced calcium absorption, the hypercalciuria secondary to the hyperparathyroidism, and reduced gonadotrophin hormones. So these are the important risk factors as far the COPD is concerned. The inhaled corticosteroid, I said, is very less of the dose, and you can see that we are using 1000 milligram, 800 milligram, but at times we are supposed to use more than 2000 milligram of the budesonide, and at times more than 1500 microgram of the fluticasone. So the patient is in low risk when inhaled corticosteroid used in 800 to 1000 microgram a day of doses. The moderate risk when we are using more than that of 800 to 1000 microgram for at least 6 weeks in a 6 month time, and high risk when we use a systemic corticosteroid, oral corticosteroid therapy in a patient of COPD, because oral corticosteroid therapy is to be given in a patient is definitely indicated in a patient of COPD when patient is going in acute exacerbation. At times patient, especially patients who are cases of the asthma COPD overlap syndrome, and the patient of COPD having the eosinophilic problem, are the candidate to receive the oral corticosteroid therapy also. As for what is the role of vitamin D in causing the osteoporosis? The vitamin D is important for keeping the bones strong and preventing the bone disease osteoporosis. Vitamin D help your intestine to absorb calcium from the food you eat. Getting enough of both the nutrients is an important part of making sure your bones are dense and remain strong. So vitamin D, the main function of vitamin D is to extract the calcium from the intestine. What is the optimal dose of the calcium? The optimal intake of calcium and vitamin D is 200 milligram of calcium and 800 units of the vitamin D, especially for those type of situation in a post-menopausal lady. What about the pre-menopausal lady and the men who are having the COPD problem and who are using the inhaled corticosteroid and at times acute aggravation the systemic corticosteroid? In such type of the situation, the dose is slightly less, 1000 milligram of the calcium at 600 international units of the vitamin D are sufficient. So these are the doses, both at treatment doses and preventive doses should be given to all those patients who need it. As the severity of the COPD increases, the vitamin D level decreases. Because vitamin D is having some proportionate increase. As the amount of vitamin D level increases in the plasma, FEV1 also increases, vice versa. As the amount of vitamin D level increases in the plasma, emphysema it decreases, and when the emphysema decreases, the vitamin D level increases. And this is the interrelationship between the FEV1 and the emphysema with the vitamin D level. Now question, have any one of us ever thought why every people who are facing pollution and environmental tobacco smoke do not suffer from COPD? We are all exposed to the environmental tobacco smoke. We are all exposed to the environmental pollution, both outdoor and indoor pollution. Why we are not developing the COPD, which is a very important risk factor as far as the COPD is concerned, both the very important risk factor. Smoking, the most important factor. The question is, does every smoker suffer from the COPD? In fact, only 25% smoker develop the COPD. Why? Because COPD is a genetically predisposed disease. It is genetically defined. There are genes, unless you are having particular genes, set of the genes, you may not develop any amount of cigarette you smoke, any amount of pollution you are exposed, any amount of environmental tobacco smoke you are exposed. So the COPD is a genetically defined disease. Only those people who are genetically predefined and predisposed develop the COPD. And another factor which is genetically predefined, alpha-1 antitrypsin deficiency. What about the alpha-1 antitrypsin deficiency? The alpha-1 antitrypsin, the main role of the alpha-1 antitrypsin is it protects the tissue damage from the non-specific neutrophil proteolytic elastase enzyme. But when there is deficiency of alpha-1 antitrypsin, it causes development of emphysema, development of the COPD. And what happened when alpha-1 antitrypsin deficiency is there? It interferes the proteolytic activity of the alpha-1 antitrypsin deficiency predisposes patients who are developing the lung damage and emphysema of the COPD. Osteoporosis is recognized as one of the comorbidity among the other common findings in alpha-1 antitrypsin disease. Hypoxia is one of the very important association with the COPD. So what is the relationship of the hypoxia with the osteoporosis? I'm sorry, I'm not able to get the slide which is to be here. So the hypoxia decreases the osteoblastic activity, which is the bone forming activity, and it increases the osteoclastic activity almost more than threefold. So bone resorption activity is there, and this is what is the action of the hypoxia. So hypoxia, which is very important association with the COPD, is also associated with the one of the risk factor for the development of osteoporosis. Reduced physical activity. A patient who is a dyspneic, how can he perform the physical activity? A decreased physical activity is an important association with the COPD, and when it is decreased physical activity, decreased mechanical load and reduced body mass, BMI and fat-free mass. You will find many of the COPD patients lean and thin, and that again can reduce bone formation. Almost 2/3 of the COPD patients suffers from low BMI, low fat-free masses and sarcopenia. All the environmental factors which are responsible for COPD are responsible for the osteoporosis as well. The smoking is responsible and most important factor as far as the COPD is concerned. It is also responsible for causing the osteoporosis. The indoor air pollution, considered to be one of the very important cause of COPD, at least in our part of the country. And it is also responsible, indoor air pollution is also responsible for causing the COPD. The pollution, which is pollution and the systematic inflammation, increased free radicals and oxidative stress, which is responsible for COPD, is also responsible for osteoporosis, and occupational dust and chemicals also having the relationship with COPD also. How to deal with the osteoporosis related with the patient by the physician? I'm not talking of the orthopedic surgeon. Suppose patient is with you, how you will deal with the patient of osteoporosis? Both the preventive activities and the treatment activities. The non-pharmacological treatment. What you will do? The cigarette, cessation of cigarette smoking is one of the very important factors. Is reversible risk factor for osteoporosis and smoking cessation result into the improvement of bone mineral density. It has been observed that those persons who stopped smoking, probably they can regain their bone mineral BMD activity. The pulmonary rehabilitation program is a moderate to severe COPD, such as counseling, fall trauma prevention are useful. The pulmonary rehabilitation, which is one of the neglected area in our country, is one of the very important factor as per the development of the osteoporosis concern. If the patient is active, probably lesser chances of developing the COPD. In addition to the excessive alcohol intake should be avoided. Alcohol intake, excessive alcohol intake also responsible for osteoporosis. Pharmacological treatment. What will be the pharmacological treatment? When there is a low risk, calcium and vitamin D intake is to be given to the patient. Weight bearing exercises are to be advised. Discourage smoking and alcohol drinking. Check the thyroid function. And a moderate risk. The same, everything which we talked about just for the low risk. The estrogen replacement is to be done in females who are in a menopausal age. Now question comes, this is one of the very important findings. The low testosterone in chronic obstructive pulmonary. It has been observed, repeatedly observed, and repeated publications are there, that testosterone level is significantly lower in COPD patient comparing with the control subject. A restricted activity level is in correlation with the testosterone level. Those who are having testosterone level less, probably having restricted activity. Middle-aged and elderly men exhibit a decline in concentration of the serum testosterone. So, is there any role of testosterone in patient of the COPD? Especially the male patient I am talking about. The meta-analysis is that these trials found that active therapy significantly improved muscle strength, peak workload and bone density. It has been found that those patients who are elderly patient of the COPD, probably given testosterone, may help bone density. But a word of caution, though this is a publication of the meta-analysis report, but it is still not part, a testosterone treatment is still not part of the gold guidelines. One should be very careful while advising a testosterone therapy to the elderly male patient of the COPD. I just touch upon the certain innovation in the COPD therapy, treatment, medication intake. This is a new machine which is called Aerobica. It is just doing the oscillating the positive expiratory pressure.